Hello guys, and welcome to a new video. This is a continuation to our discussion about antibiotics. We already talked about an introduction video that contained the basic information you need to know to learn antibiotics. And now this video is going to be how to select or prescribe the proper antibiotic. This is very important because you are selecting and prescribing antibiotics on your practice, and it is very important for you to have a systematic method or systematic way to decide or to choose the right antibiotic for the right patient. So let's start. So how to approach antibiotic selection, or what is the approach to antibiotic selection? We are going to follow the 5 rights, which is a system or approach or method that applied to every drug, but we are going to make a version for the antibiotics. So the 5 rights: right, patient, right, drug, right route, right dose, and right duration. Right dose and right duration. So the idea is that you take into consideration all the 5 rights when you choose the antibiotic. So the right patient, right drug, right route, right dose, and right duration. And we are going to explain each one of these in the next slides. So let's start with the right patient. So the right patient. So what are you going to consider in choosing the right patient who are going to receive the antibiotic? So firstly, you want to confirm that the patient have infection. So confirm infection. So how you confirm infection? All bacterial infection are accompanied by the rising of the body temperature, which is fever. So all the bacterial infection are accompanied by fever, which is the rising of a blood temperature more than 37.2. So all bacterial infections are accompanied by fever, except in patients who are immune compromised. So except patients who are immune compromised, they would not have fever associated with their infection. Immune compromised meaning their white blood cell count is less than 5,000. So they would not have the normal response to infection, so they would not have fever. So all bacterial infections are accompanied by fever, but the opposite is wrong. So not all fevers mean bacterial infection, because the fever sometimes mean bacterial infection, but some other time might mean infection. It also might mean allergic reaction or cancer or some other stuff that cause fever. So all bacterial infections cause fever, but not all fever mean bacterial infection. So if the patient has fever, this patient is suspected for having infection. The other thing that you use to confirm infection is the complete blood count, which is a laboratory investigation. And from the white blood count, you pay attention to some specific stuff that you need. So you pay attention for the white blood cell count and the normal is from 5,000 to 10,000. And the rising of the white blood cell count makes the patient maybe having bacterial infection. And you also look for the neutrophil count, which would be 70 or 60 to 70%, 60 to 70% of the white blood cell count, and the neutrophil fight bacteria. So fight bacteria. So if the neutrophil count is raised, this means the patient has bacterial infection. You also pay attention to the lymphocytes. The lymphocyte count, which is 30%, and if it is raised, so the lymphocyte fight viruses, lymphocyte fight viruses and TB. So if the lymphocyte is raised, this might mean the patient have a viral infection or tuberculosis. You also look for the eosinophils count, eosinophils, and it is from 4 to 10%. And if it is raised, it might mean an allergic reaction, or it also might mean a parasitic infection. You also look for the basophils count, and it should be less than 1%. And if it is raised, this is bad, and it might mean the patient have leukemia or lymphoma, which is blood cancers. And you also do specific tests. Specific tests like chest X-ray. If the patient is coughing, you do chest X-ray, maybe to confirm pneumonia infection. So if the patient is coughing, you do chest X-ray. If the patient have urgency and frequency of urination, you do general urine exam. So general urine exam if the patient have an urgency and frequency, and so on. You calculate body temperature, you do CBC, and you do specific tests to confirm that the patient have infection. And this is for the right patient. Now let's move on to the right drug. How you decide the right drug for the patient. So in choosing the right drug, you consider 3 things. You consider the type of infective organism, so type of infective organism, and patient factors, and also you take into consideration the tissue penetration, if the drug is going to reach the infection site or not. Now let's talk about how you check for the type of infective organism. Type of infective organism. So the method is that you take infective material from the patient, and send it for culture and sensitivity. Infective material and send for culture / sensitivity. Infective materials include cerebrospinal fluid. If you suspect the patient have meningitis, you take cerebrospinal fluid and send it for laboratory for culture and sensitivity. Also infective materials is urine in patients who have urgency, frequency, some urinary symptoms. Also, throat swabs are also infective in patients who are coughing, throat swabs. And blood, if the patient have bacteremia or septicemia, you take blood and you send it for culture and sensitivity. Culture means identifying the organism, and the sensitivity is testing which drug is susceptible is the organism more susceptible for, so susceptibility of organism. Now the culture and sensitivity takes about 2 to 3 days until the result is out and you decide the drug for the patient. But some of the times you can't wait for 2 to 3 days to treat infection. So you give antibiotic without knowing the infective organism. So sometimes you give antibiotic without knowing the infective organism, without identifying organism. And that's what we call the empirical therapy. So when are you going to give the patient empirical therapy? So empirical therapy indications, empirical therapy indications. We give empirical therapy in acutely ill patients, so acutely ill patients, because we can't wait for 2 to 3 days because the patients are acutely ill and they might die during that time. We also give empirical therapy in patients who are immunocompromised. Their white blood cell count is less than 5,000, so you consider giving them empirical therapy because they are more liable to infections and they don't develop the infection symptoms like fever until the infection is complicated and it is hard to treat. So we also give empirical therapy in patients who are suspected to have meningitis, and that's the patient who have symptoms like severe headache and also photosensitivity and neck rigidity. So it is hard for them to move their neck. So we suspect them to have meningitis. This is the triad: headache, photosensitivity, and neck rigidity. If the patient have that triad, you suspect them to have meningitis, and you take, so after that, you take CSF specimen, cerebrospinal fluid specimen, and after you take the specimen, after that, you quickly start the empirical therapy. So just in case your empirical therapy did not work to kill the meningitis, to treat the meningitis, you have already a CSF material, and you can, after 2 to 3 days, you have the results of the sensitivity and you can decide the antibiotic then. Now, so those are the indications for the empirical therapy. Now, how we decide the antibiotic for the empirical therapy? So we just here assuming the organism, and we give the antibiotic according to our assumption. So how to decide the antibiotic type. And now we decide that depending on the site of infection. So site of infection, because every infection site or every site in the body have a specific organism that commonly affect that site. So we need to consider that. We also would consider the patient history. The patient history, including the recent travel history, because if the patient traveled to place endemic with an infection, you would expect the patient to have that infection. You also take into consideration the patient age, because people who are too young or too old are susceptible to infections which are different from the infections that the adults or the patients between too young and too old have. You also take into consideration the patient immune system, also the if the infection is hospital or community acquired. So hospital or community acquired, because the hospital acquired infections usually are resistant infections and need more aggressive therapy. And you also take into consideration the previous antibiotic treatment, because if the patient take broad spectrum antibiotic, you expect them to have certain infections like Clostridium difficile infections or Candida infection. And in empirical therapy, it is very important, so note, it's very important to take a specimen from the patient, from the infective material, then you give the empirical therapy. Because just in case your empirical therapy or your assumption didn't work, you have the specimen that you sent for the laboratory, and it is going to be out in 2 to 3 days, and you would have the results, and you would have the antibiotic is most the infection susceptible for. So note, take a specimen before starting the empirical therapy. Now let's talk about the patient factors. So patient factors in choosing the right drug. So in patient factors, you need to consider the age group of the patient, because some drugs you can't give for certain age groups. And here some examples about the age group. So neonates can't take chloramphenicol and phenicol and sulfonamides. Chloramphenicol cause gray baby syndrome if given to infants, gray baby syndrome, and sulfonamides cause kernicterus. So those drugs are contraindicated in neonates. Another example is that in the children age group, you can't give the tetracycline because it causes the abnormal teeth formation in the children, abnormal teeth, and you also can't give the children fluoroquinolones. Fluoroquinolones, because fluoroquinolones cause the child to have articular damage. In old people, which is the old age group, you can't give them the aminoglycosides. Aminoglycosides, because it causes severe ototoxicity and nephrotoxicity. Also, the pregnant ladies, so pregnant ladies, you can't give them the fluoroquinolones because they pass the placenta and cause articular damage to the fetus. Articular damage. You also can't give them the aminoglycosides because they cause congenital deafness in the fetus. Congenital deafness. Now also the immunocompromised patients. So immunocompromised, you can't give them the bacteriostatic drugs because they arrest the bacteria growth and they wait for the immune system to kill the bacteria. But if the patient is already immune compromised, the immune system can't kill the bacteria, so it is better to give them bactericidal drugs. Patients who have renal dysfunction, you need to careful dose adjustment and monitoring. So you need to be careful in adjusting the dose so they don't have the antibiotic rising above the and causing toxicity to the patient. Next, you need to consider if the drug is going to reach the infection site or not. So tissue penetration, consider if the antibiotic is going to reach infection site. Like in people who have diabetic foot, those people have ischemia to their foot, and the blood don't reach well into the ischemic foot, so the antibiotic would not reach. So it is better for these people to have excision and debridement of their ischemic parts of their foot, and then would be given antibiotic. So the antibiotic would work well. Also in people who have a chronic abscess, abscess, there is already a fibrous layer that is making a lining into the abscess, so it is impossible for the antibiotic to reach into the inside of the abscess. So the chronic abscess is treated with drainage, incision and drainage, or aspiration. Then the patient is given antibiotic. Also, another example is the natural barriers. So natural barriers like a blood-brain barrier and blood-eye barrier, blood-prostate barrier, and some more. So in treating infection in these sites, it's better to give the antibiotic directly into the infection sites, like giving the antibiotic intrathecally into the spinal cord, so it reaches into the cerebrospinal fluid. but sometimes you choose antibiotic that can go through the barrier, and it is best with antibiotics that have high fat solubility and low molecular weight. They can penetrate into the natural barrier, and they work well with infections that happen in the body parts that have natural barriers. So, in summary, regarding the right drug, so in the right drug, we talked about how we need to identify the infection, so identify the organism type, and that's through taking a specimen and sending it for culture and sensitivity. So you need to identify the organism. If you can't identify the organism, you can go into empirical therapy, which is giving antibiotic without knowing the organism. You just assume that or expect the organism, depending on several things that I talked about in the previous slide. You also, in the right drug, you consider the patient factor. So you consider if the drug is suitable for the patient age group, and if the patient is immunocompromised, or if the patient is pregnant. So you need to consider the patient factor in choosing the right drug. And we also talk about the tissue penetration. So if the antibiotic is going to reach the infection site. So that's regarding the right drug. So now let's talk about the right dose. So in the right dose, we need to first explain the minimal inhibitory concentration. So minimal inhibitory concentration, it is the minimal concentration by which the antibiotic kills the bacteria. So minimal concentration by which antibiotic kills the bacteria. And according to the minimal inhibitory concentration, we have three types of killing. We have concentration dependent killing and dependent killing. We have also time dependent killing, and we have the post antibiotic effect. So post antibiotic effect. So in concentration dependent killing, the antibiotic kills the bacteria more if the antibiotic is at higher concentration in the plasma. And example for that would be the gentamicin, which is an antibiotic from the aminoglycosides, and this antibiotic kills the bacteria more if its level or concentration at the plasma is higher. And that's why it is given once daily in high dose to achieve the concentration dependent killing. Now for the time dependent killing, the antibiotic kills the bacteria while being available in the plasma for longer time. And of course it would be available at level which is higher than the minimal inhibitory concentration. But the more time it is available at the plasma, it kills more bacteria. An example for that would be the penicillin. And that's why the penicillin dosed for 4 times a day every 6 hours, because the more or the longer the time the penicillin is in the plasma, it would kill more bacteria. We also have the post-antibiotic effect, which happen in antibiotics that even after the antibiotic concentration is diminished in the plasma, the antibiotic is still killing the bacteria by the post-antibiotic effect, and that's when the antibiotic is concentration at the circulation is diminished, but its concentration at the infection sites and at the macrophage is still high. And example for the post-antibiotic effect, it happens with antibiotic like fluoroquinolone, and also for antibiotic class called macrolides. And that is regarding the right dose. Now let's talk about the right route. So usually for the severe infections, we use the intravenous route. We deliver the antibiotics directly to the blood because they reach the circulation faster and they would have faster effect, because those patients who have severe infections are more liable to complications. So it is better to give the antibiotic as quickly as you can through the intravenous route. And for the mild infections, you would usually use the oral route. And that's regarding the route. Now let's talk about the right duration. So every infection have a duration that already determined by the general guidelines. Examples for that, the acute rhinosinusitis is treated in a duration from 3 to 5 days. The community acquired pneumonia is treated in a duration from 5 to 7 days. And we have the acute otitis media is treated from a duration treated in duration from 5 to 7 days also. Now it is better to continue the antibiotic for 2 to 3 days after full resolution, just to make sure that we killed the infection and to prevent the emergence of resistance if the infection is relapsed in that patient. Because if infection is relapsed in the patient, the antibiotics the antibiotic that you use the previous time is not going to work this time, because the bacteria is already developed resistant patterns to that antibiotic. So it is better to continue the treatment for 2 to 3 days more, just to make sure that you kill the infection well. And that's it for this video. Thank you guys for watching. Please like, subscribe and share the channel with your colleagues.